Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to my channel of Easy Medical Notes, which is a summary of standard medical textbooks like Harrison, Davidson, McMaster, Oxford. Previously, we had discussed the topic of cough, which is a cardinal symptom of a respiratory system. Now we will be discussing about another cardinal system, which is very common in emergency rooms, that is breathlessness or dyspnea. So let us start by the definition of breathlessness or dyspnea. What is the definition of breathlessness? Breathlessness or dyspnea can be defined as the feeling of uncomfortable need to breathe, or in other words, it can be defined as uncomfortable awareness of one's own breathing. Uncomfortable awareness of one's own breathing. Normally, we don't have awareness of our breathing, and it is not uncomfortable also, but when there is pathological when there is some pathology, due to that there is breathlessness, then we will be we will get aware about of that breathing, and that breathing will be uncomfortable to us. So that is breathlessness. So what is the etiopathogenesis of breathlessness? So breathlessness can be due to respiratory disorders or cardiac disorders. So the mechanism by which respiratory diseases can stimulate breathing or dyspnea are three mechanisms. Number one is stimulating the intrapulmonary sensory nerves. Those will give signal to the respiratory center in the medulla, and from there to the cortex, motor cortex, from the motor cortex to the respiratory muscles, and then breathlessness will develop. So example for that, for the stimulation of intrapulmonary sensory nerves include pneumothorax, interstitial inflammation, and pulmonary embolism. Second mechanism is increasing the mechanical load on the respiratory muscles, meaning there is load on the respiratory muscles. Example in airflow obstruction. So there are airways like bronchi, small bronchioles, or large bronchi. If there is obstruction, like in some foreign body or some asthma or COPD or pulmonary fibrosis, then expiration becomes difficult. That causes load on the respiratory muscles. Respiratory muscles has metaboreceptors. Those metaboreceptors give signal to the respiratory center, and respiratory center will stimulate breathing. The third mechanism is, so because of improper uh, oxygenation of the blood, there will be hypoxia, hypercapnia, increased carbon dioxide, acidosis. So all of these three will stimulate the chemoreceptors. Peripherally, they are situated in the carotid body at the bifurcation of a carotid artery, and also the central chemoreceptors. So those will stimulate the respiratory center, and there will be increased rate of respiration. So that's about the common mechanisms of common pulmonary mechanisms which cause breathlessness. First one is stimulating the intrapulmonary sensory nerves. Second is increasing the mechanical load. Third is causing hypoxia, hypercapnia, acidosis. So here is the figure which shows that thing. See, so airway obstruction like asthma and emphysema. I will zoom this image. Airway obstruction like asthma and emphysema, and pulmonary fibrosis. These will cause increased mechanical load and also hypercarbia and acidosis. So that will stimulate the respiratory center, and from there signals will go to the respiratory muscles and breathlessness. And intrapulmonary sensory nerves. So vagal efferents will take the signals. For example, in the pulmonary arteries, like in pulmonary embolism and in interstitial disease due to some inflammation or infection or fibrosis, or deflation in pleural, intrapleural nerve endings like in pneumothorax or collapse or effusion. All these will go to the respiratory center and they will stimulate the breathing. Apart from this, you can also see there are links between the limbic system and the respiratory system. That's why whenever there is some psychiatric disorder like anxiety disorders, there will be breathlessness. Apart from that, also there is connection between the cerebral cortex and the medullary respiratory system. That's why we can control we can partially control our respiratory rate, apart from uh, control from the autonomic nervous system when we are not aware of that. So these are the mechanisms by which uh, causes co- pulmonary causes cause breathlessness. Cardiac, how does cardiac breathlessness cardiac causes cause breathlessness? Reduced cardiac output limits oxygen supply to the skeletal muscle during exercise, causing lactic acidosis. So that will stimulate the central chemoreceptors. This is one thing. Second thing is back pressure. Back pressure due to cardiac causes will cause pulmonary congestion. Pulmonary congestion. This is the second thing. So these two causes will cause breathlessness in cardiac disease. This is one more figure which is illustrating the same. Hypoxemia, hyperchemia, hyperacidemia will stimulate the central chemoreceptors and peripheral chemoreceptors. Afferent signals will be taken to the brainstem. Patient will describe the breathlessness as air hunger, brainstem and sensory cortex. In case of airway resistance and decreased lung or chest wall compliance, there will be mechanoreceptors in the upper airways, lungs and chest wall, or metaboreceptors in the skeletal muscles. Patient will describe this as chest tightness. These signals are sent to the brainstem. From the brainstem uh, to the motor cortex, and from the cortex to the respiratory muscle. So why do we feel that we are having breathlessness? This is because motor cortex, apart from sending signals to the respiratory muscles, it also sends signal to the sensory cortex. That's why we feel that. Next, coming to the causes and clinical features of breathlessness. First cause is pulmonary. So pulmonary causes can be divided into airways diseases, parenchymal diseases. Parenchymal meaning the functional tissue of the lung. Functional tissue of the lung is referred to as parenchyma. Airway disease, parenchymal disease, and chest wall disease. Parenchymal airways disease include example for those most commonly asthma, COPD, or upper airway obstruction. Presenting complaints: chest pain, So basically, remember, patient will describe the breathlessness as three things. Three things. Number one, air hunger. Air hunger. Number two, chest tightness. Chest tightness. Number three, difficult difficult to take deep breath. These three things patient will tell. Okay, presenting completely among these three things. So, what physical findings? With there will be wheezing, particularly in asthma. This is the typical feature of asthma. It is also seen in cardiac causes and COPD also, but the typical feature of wheezing is asthma. And exertional hypoxemia or exertional breathlessness, typical feature of COPD. Mechanisms we have learned. So, what are the investigations? Number one, peak expiratory flow meter. So, that is reduced in obstructive airway diseases. This is particularly used in gauging the severity of breathlessness in asthma. And if you do, the second one is spirometry. If you do, then uh, it will show obstructive ventilatory drive, meaning the cause is one of obstructive airway disease. So the diseases of the lung can be divided into two. One is obstructive, second one is restrictive. Obstructive lung disease LD and restrictive lung disease. Obstructive lung disease, there is obstruction to the airways, obstruction of the airways, so the patient can't exhale easily because of the obstruction. Maybe due to it may be due to bronchospasm, or it may be due to some foreign body. Restrictive lung disease, meaning the parenchyma of the lung is lost, so patient will not have space to have air in the lungs. So that is restrictive lung diseases, broadly classified into two. So in spirometry, because it is airway disease, it will show obstructive cause. Chest X-ray will show hyperinflation and loss of lung parenchyma in COPD. Chest CT also you can do, and airway examination for any upper airway obstruction. So these four are the basic investigations of any pulmonary disease. One is peak expiratory flow meter. Second one is spirometry, chest X-ray, and CT, HRCT, high resolution CT scan. These four are the basic investigation of pulmonary system. Okay, coming to the parenchymal disease, interstitial lung disease. So it is a broad term which encompasses many diseases, most common of which is idiopathic pulmonary fibrosis. Number one. Number two, it can be due to some connective tissue disorder. Number three, it can be due to sarcoidosis. Number four, uh, it can be due to hypersensitivity pneumonitis. Hypersensitivity pneumonitis. What is hypersensitivity pneumonitis? Typical example is methotrexate toxicity. Any patient receiving methotrexate for rheumatological disorder can develop hypersensitive pneumonitis. In this, lungs are damaged by the autoantibodies. Parenchyma is replaced by fibrous tissue. So, these are the examples of interstitial lung disease, most common of which is idiopathic pulmonary fibrosis. So physical findings, what you will find, there'll be dry and inspiratory crackles, there'll be clubbing, important point, and there'll be exertional breathlessness. Spirometry will show restrictive when restrictive lung disease. Chest x-ray and chest CT will also show interstitial lung disease. So that was about parenchymal disease. Third one is chest wall disease. Number one is kyphoscoliosis. Second is neuromuscular weakness. Kyphoscoliosis means abnormal bending of spine. Normally spine is straight, but in some individuals by birth, the spine will be bent like this. So due to that, they will have breathlessness, because the reason is they will be having decreased diaphragm excursion, and they'll having atelectasis. So spirometry, if you do, you will have restrictive ventilatory drive, or it will show restrictive disease pattern, because parenchyma is there but muscles are not, uh, because there are disturbance in the muscles are weak. That's why those muscle can't stretch the lung to have air inside. That's why it will show restrictive pattern. If you do MIP, maximum inspiratory pressure and maximum expiratory pressure, it will be reduced. Because why? Because there is reduced in the neuromuscular system. Reduced, I mean, there is weakness in muscles. That's why. So these are the causes of, these are the pulmonary causes. Airway disease, most common of which is asthma, COPD, parenchymal disease, interstitial disease, chest wall disease, kyphoscoliosis. Second one is pulmonary vasculature. Example is pulmonary hypertension, most common. Presenting complaint tachypnea. In severe cases, it can present as exertional breathlessness because of right ventricular hypertrophy, and because of right ventricular hypertrophy. On examination, you will have elevated right heart pressures. There will be elevated JVP, increased uh, jugular venous pressure. Okay, and if severe, they can be pedal edema also, bilateral pedal edema, and there will be exceptional breathlessness. Diffusion capacity, if you measure, it will be reduced. ECG, if you do, then you will find P pulmonale before the QRS, QRS complex. P pulmonale meaning, properly if you see in second lead or V1. Okay, in second lead, what you will see, P wave will be tall, more than 2.5 small square in length. This one you will see in second lead. And in V1, P wave will be biphasic actually, normally. So the first part of P wave, it will be like this. But in case of pulmonary hypertension, it will become like this, in pulmonary hypertension. And this is normal cases. That is in pulmonary hypertension. And if there is associated right ventricular hypertrophy, then you can also find right bundle branch proc. Also RSR dash pattern, RSR dash, this is small r, this is big S, and this is R. So M pattern, also called M pattern, RBBB with M pattern or RSR dash pattern in case of right ventricular hypertrophy in V1 and V2. You can do echo to confirm that. pulmonary hypertension. Next, coming to the cardiac causes of breathlessness. Cardiac causes can be divided into. So this is pulmonary hypertension is nothing but right right heart failure, actually. Right heart failure. Here it is left heart failure. So left heart failure can be due to coronary artery disease or cardiomyopathy. In coronary artery disease, so this is the coronary artery which is supplying blood vessels. There will be some fixed atheromatous plaque, this much, which will be reducing the blood flow to the muscle, respiratory muscle, to the left ventricle. So what happens because of the reduced blood flow, uh, pumping of the blood is impaired. That's why cardiac output is reduced, back pressure to the lung, so there will be breathlessness. Cardiomyopathy, what happens? In cardiomyopathy, the muscle mass is increased. In cardiomyopathy, cardiac muscle mass is increased and the ventricles are stiff. That's why uh, that's why blood cannot fill the ventricles. So this is a type of blood cannot fill the ventricles. Therefore, there will be end diastolic volume will be reduced cardiac output. Again, there will be pulmonary congestion backside. So there will be breathlessness along with fatigue. Okay. So there will be breathlessness. There will be elevated left heart pressure. On examination, you will hear wet crackles on lung examination. And second one is, so this is right heart, pulmonary hypertension is nothing but right heart failure. And this is left heart failure. So next one is pericardial disease. Common examples are constrictive pericarditis and cardiac tamponade. Constrictive pericarditis, where you will see most common example is tubercular pericarditis, which will in some patient end up with the fibrosis of the pericardium that will cause uh, constrictive pericarditis. It is very bad thing which happens, bad condition, constrictive pericarditis. And second one is cardiac tamponade, where this is the heart and this is the parietal pericardium. In between this there will be pericardial fluid. When this is increased so much that heart is not able to expand and take the blood, and this should be very massive. This fluid should be massive. So that is called as cardiac tamponade. So cardiac tamponade, remember triad of cardiac tamponade, also called as Beck's triad. First thing, there will be hypotension. Second one is increased jugular venous pressure. Third one is muffled heart sounds. This is also known as Beck's triad. Muffled heart sounds. This is in cardiac tamponade. Okay. Next, whenever there is heart failure, you can consider to confirm the heart failure BNP testing. But remember, there are two types of BNP: pro BNP and anti-pro BNP. Anti-pro BNP. This is not used because this is altered in many conditions. This is used commonly, and there are cutoffs based upon ages, which we will discuss in investigation part. You can do ECG. In ECG, in coronary artery disease, if there is angina, you can see the ST segment depression in leads which are supplied by that artery. ST segment depression. ST segment depression. This is the T wave. Okay. Similar changes you can see in cardiomyopathy because there is demand and supply mismatch. That's why anginal changes you can see in cardiomyopathies also. In case of pericarditis, acute pericarditis, the ECG findings, the most common ECG finding is diffuse ST, diffuse ST segment elevation, diffuse ST segment, sorry, diffuse ST segment elevation like this. It will be concave upward. In MI, it is convex upward. In pericarditis, it is concave upward. And almost all of the leads are involved in pericarditis. Whereas in MI, if it is inferior, 2-3 AF are involved. If it is lateral, other leads are involved. It is anterolateral, it is MASU. So depending upon the arteries involved, the leads having that will have changes of ST segment elevation concave upwards. In cardiac tamponade, there is one sign you can find. In cardiac tamponade, generally you will have the complexes will be small complexes. You will see small complexes. The amplitude of complexes will be reduced. Number one point. Number two, there is one sign called electrical alternance. Electrical alternance you can see, but it is not specific. You can not specific means it is not necessary that you can find this. What is electrical alternates? One QRS complex will be high, second QRS complex will be low, and then the third QRS complex will be high amplitude. Then alternate QRS complex will have one high, one low, one high, one low. This is known as electrical alternance. So first is amplitude of the QRS complexes decrease, and in electrical alternance, alternately the QRS complex amplitude is high and low. That is known as electrical alternance. In acute setting, you should order BNP, anti-pro-BNP. ECG echo can be done, and you will need stress testing also. So that's about the cardiac causes. Other causes you can divide into metabolic causes, metabolic and psychogenic, psychiatric causes. Metabolic causes include anemia, deconditioning, and psychological causes, anxiety, depression. Metabolic causes anemia, deconditioning. Next is metabolic disturbances like diabetic ketoacidosis, renal disease, CKD. Okay, poisoning like salicylate poisoning, ethylene glycol poisoning, metformin associated lactic acidosis. All these are causes for metabolic causes of breathlessness. Psychogenic, panic attack. So that will have this one. In anemia and deconditioning, you will have exertional breathlessness and fatigability. Easy fatigability is the hallmark of this one. Metabolic cause, easy fatigability. One acute condition is diabetic ketoacidosis. Others are chronic, and the patient will complain of easy fatigability. So hematocrit for anemia, metabolic panel disorder, meaning that LFT, RFT, electrolytes, TFT, these you will order. Okay, so that's about the causes and brief clinical features and findings and investigation of breathlessness. Okay, now breathlessness can also be divided upon the duration of onset of breathlessness. It can be acute. Acute meaning onset from minutes to hours to days. Chronic means from days to weeks to months. This is chronic breathlessness. Okay, so number one cardiovascular cause is acute pulmonary edema. Respiratory common cause are acute severe asthma, COPD, pneumothorax, pneumonia, pulmonary embolism, inhaled foreign body in children, and remember anaphylaxis, laryngeal edema. Other metabolic causes are diabetic ketoacidosis, lactic acidosis, uremia, CKD, salicylate poisoning, ethylene glycol poisoning, and one more is metformin associated lactic acid mala. This is usually seen in CKD patients who are taking high dose of metformin. This is third cause, metabolic. Fourth one is psychogenic hyperventilation, anxiety or panic related. These are all acute causes of breathlessness. Then what are the chronic causes of breathlessness? Those include chronic heart failure. Second is myocardial ischemia, also known as sometimes instead of producing pain, exertional pain, some patient have breathlessness. Instead of pain, they will have breathlessness. That is called as angina equivalent. Why breathlessness? Because of ischemia, left ventricle will not pump properly, and the end diastolic volume is raised. That will cause back pressure, that will cause pulmonary congestion and breathlessness. That's why sometimes some patient instead of having chest pain, they will have breathlessness, which is equivalent to that anginal pain. That is known as angina equivalent. So these are the cardiac causes of chronic dyspnea. Chronic heart failure. Chronic heart failure is nothing but right heart failure plus left heart failure. Both eventually one side failure will cause second side failure. Uh, Then respiratory common causes are COPD, asthma, interstitial lung disease, lung cancer. Metabolic causes include severe anemia, obesity. Now first we will discuss in detail acute breathlessness. So whenever a patient comes with acute onset of breathlessness, then first you should rule out three things: airway obstruction, airway obstruction, number one. Number two, anaphylaxis, anaphylaxis. Number three, pneumothorax, pneumothorax. If these are not there by history or clinical examination, then you should move on to cardiac causes of acute breath, cardiovascular cause. Cardiovascular cause. So in that, first cause is pulmonary edema. So history will reveal chest pain, palpitation. Orthopnea is very important feature of cardiac heart failure, although it can be seen in COPD patient also, but typically this orthopnea is seen in uh, patients with cardiac breathlessness, cardiogenic pulmonary edema. What happens? When patient wants to lie down, he will have excessive breathlessness along with pink frothy sputum. When he goes to lie down, means when he tries to lie down, he will have breathlessness along with cough, increased cough. So patient prefers to sleep in the sitting position. So that is the hallmark of cardiogenic pulmonary edema. And you will have some cardiac history, that he had some previous myocardial infarction, or he has some angina, or he has some valvular defects, you will have. So this is one discriminatory star mark, means good discriminative feature in history. What are the signs? They can be cyanosis. JVP will be raised. In JVP, jugular venous pressure will be raised because of activation of autonomic nervous system. There will be sweating also. Decreased cardiac output causes cool extremities. Pulmonary edema meaning acute left ventricular failure. So basal crackles. So in all these, important one is important one is raised JVP and bilateral basal crackles. These indicate acute left and ventricular failure. Along with that, you can have chest pain. Uh, all acute causes should have these three investigation. First line investigation: chest X-ray, ECG, ABG. So in case of pulmonary edema, you can see cardiomegaly, pleural effusion also. Pleural effusion. This is a discriminative feature. Pleural effusion is usually uh, not seen in here. Okay, and in ABG, there will be decreased oxygenation, decreased partial pressure of oxygen, and decreased partial pressure of carbon dioxide. ECG will show some arrhythmia or ischemia or sinus tachycardia, like in pulmonary thromboembolism. Just it will show a sinus tachycardia, that's all. So those are the changes in pulmonary edema. Next, you should think about, after ruling out pulmonary edema, you should think about massive pulmonary embolism. So there will be history of risk factors with them, means diabetes mellitus, patient will have hypertension, smoker, dyslipidemia. These are all the risk factors, and CKD, very important risk factor. These are all risk factors for uh, both for all cardiac causes of breathlessness. These are all risk factors. If these are there, then you should suspect any cardiac cause for breathlessness. And you can have chest pain, pleurisy. Most important discriminative feature is syncope and dizziness. Syncope and dizziness. And the patient will have increased JVP, and there will be no lung signs, but there will be patient will be in shock. So absent lung signs, but with increased JVP, no lung signs, increased JVP, and hypotension, tachycardia, that indicates patient might be in massive pulmonary embolism. Chest X-ray shows oligemic lung fields, means the blood supply to the lungs are reduced. Those you can see in a chest X-ray as oligemic lung fields. So in ABG, decreased oxygen, decreased carbon dioxide. And ECG will show sinus tachycardia. Most common finding in ECG is sinus tachycardia and RBBB. Sinus tachycardia and RBBB in massive pulmonary embolism. S1Q3 T3 pattern is very rarely seen in case of pulmonary embolism. So most common signs which are seen in massive pulmonary embolism are sinus tachycardia, RBBB, and increased T waves from V1 to V4. This is very rarely seen. After ruling out cardiovascular cause, come to the pulmonary cause. The first is acute severe asthma. There will be history of asthma, allergy. Okay, history of wheeze will be there, which is very important. This only feature. And JVP will be normal, indicating there is no some cardiovascular cause. There will be wheeze. This is very important distinguishing feature of asthma. And if you order chest X-ray, there will be hyperinflation of it, because there is it is an obstructive lung disease. So, and in ABG, decreased PO2, then decreased PO2. And if the asthma is severe, very severe, and if very severe asthma, uncontrolled asthma, you can also have hypercarbia, meaning type 2 respiratory failure. There will be tachycardia in ECG. So main is wheeze along with hyperinflation and will history. This will tell us the cause of asthma. Then second common cause, pulmonary cause, is acute exacerbation. What is exacerbation? We will hear about acute exacerbation of asthma, acute exacerbation of CD. So the disease is like this disease is running in the baseline. Some due to some reason, some infection, the disease will go for some time like this. At this time, you will intervene by giving drugs so that the disease returns to its baseline, but still it remains in the baseline. Again, some due to some cause it will go up, and after intervention it will come down. So these spikes are nothing but exacerbations of asthma or exacerbations of COPD. These are called as exacerbations. So in COPD, most there will be previous episodes. This is the most important feature: smoking history. In type 2 respiratory failure, patient may be drowsy because of hypercarbia. Carbon dioxide is retained. So one important point is morning headache patient will have. A chronic smoker having morning headache, suspect type 2 respiratory failure. Signs, there will be cyanosis, and there will be signs of carbon dioxide retention. Very important point. Flapping tremor you will see, and you will see there will be signs of carbon dioxide retention. Signs of carbon dioxide retention. Flapping tremor, meaning you tell the patient to do like this, and you just press the hand like this. So hand will become like it will flap like this. This is nothing but flapping tremors. So that means the patient is having carbon dioxide retention. And next one is flapping tremor. One thing is flapping tremor. Second thing is bounding pulses. Patient will have bounding pulse. Chest X-ray, you will have hyperinflation. You can also have some bulle. Bulle means this is the lung tissue, trachea and all. So like thin walled sacs will be there, filled with air, which can rupture at any time. Those are called bulle. Those bulle can complicate into pneumothorax. This will rupture and have air in between the pleural cavity and pleural cavity. That will cause pneumothorax. So in history, smoking is very important. Previous episode is important, and signs of carbon dioxide retention. These are better. In chest X-ray, there will be hyperinflation, and you can also say bulle. And in if the patient is not in type 2 respiratory failure, you will have only decreased hypoxemia. And if he is in type 2 respiratory failure, along with decreased PO2, he will also have increased PaCO2. Usually in chronic type 2 respiratory failure, as a compensatory measure, these COPD patients will have increased bicarbonate. If there is no increased bicarbonate, that means the patient is a not chronic patient for type 2 respiratory failure. Normal or signs of this can be there. Any lung disease can cause right heart hypertrophy and right heart failure, that is called as cor pulmonale. So you can have right ventricular strain pattern, meaning in V1 and V2, you see this is the P wave by P wave, this is the QRS RSR dash pattern, this is R, this is S, and this is one more R, and this is the ST second depression, and this is the T wave, and this will go like this. So RSR dash pattern along with sloping depression of the S wave, this is known as right ventricular strain pattern, which is seen in right ventricular concentric hypertrophy. That means along with hypertrophy, the heart is having ischemia on demand, meaning patient if he does some work at the time, the blood supply to the heart is reduced. So that is the second most common cause of breathlessness. Third common cause is pneumonia. So you will have some fever, rigors, pleuritic pain. Signs: patient will have increased temperature, delirium, and if there is pleuritis, then you can have pleural rub, and signs of consolidation, bronchial breath sounds you can hear. So these are important signs of, this is the most important point of pneumonia, consolidation. Okay, X-ray will show consolidation, decreased oxygen, decreased carbon dioxide, and ECG will show tachycardia. These are the cardiac and pulmonary causes, main causes. Then metabolic causes. There will be evidence of diabetes, evidence of renal disease, aspirin or ethylene glycol overdose. On signs, there will be hyperventilation, but there will be no signs of heart or lung. There will be hyperventilation, but there will be no signs of heart or lung. There will be no wheeze, no bounding pulse, no flapping tremor, no previous history of heart or lung disease. There will be history of diabetes, there will be history of CKD, like this. But the discriminating feature here is, so one point is there will be no heart or lung signs. Second is there will be dehydration, there will be hyperventilation, and remember, even though there is hyperventilation, the SpO2 will be normal. SpO2 will be normal because of acidosis, lung will try to excrete the excessive carbon dioxide which is present in blood. So there will be no changes in oxygen saturation. That's why SpO2 will be normal, but patient will have increased respiratory rate. There will be no cardiac and lung signs, and patient will have history of diabetes, CKD, poisoning, like that. And there will be signs of dehydration. Chest X-ray will be normal, PaSO2 reduced, bicarbonate decreased, H+7 increased. Psychogenic, there will be previous episode, severe panic attack episodes, history, and there will be digital or perioral dysesthesia, tingling sensations around the mouth, tingling sensation in the fingers. Why? Because of anxiety, the patient will hyperventilate. Because of hyperventilation, carbon dioxide is lost. Excessive carbon dioxide is lost. So to compensate that excessive carbon dioxide is lost, so carbonic acid will break down into H plus and bicarbonate ions. This bicarbonate will combine with free calcium. So due to transient hypocalcemia, patient will have digital and perioral tingling sensations. Okay, this is about the acute causes of breathlessness. You should remember in this way only after ruling out airway obstruction, pneumothorax, and anaphylaxis. This video is becoming long, but this is a very important topic and it will take some time. I am not going to discuss investigation and treatment. It will be discussed in some another class. So so one type of classification is depending upon the onset that is there. Now, depending upon the posture, you can classify the dyspnea. One is paroxysmal nocturnal dyspnea. What is that? Name itself suggests paroxysmal, episodic, nocturnal, nighttime, dyspnea, breathlessness. So there is sensation of shortness of breath that awakens the patient often after 1 or 2 hours of sleep, and it is usually relieved in the upright position. This is typically seen in cardiac failure patient. Because why? Because the ventilatory drive is reduced during sleep, and venous return is increased against a failing heart. That's why after 1 to 2 hours of sleep, because of increased venous return and decreased respiratory drive, there will be pulmonary congestion, and patient will wake up from the sleep with breathlessness and try to have some air. That is nothing but paroxysmal nocturnal dyspnea. This is typically seen in cardiac failure. You should ask the patient for history of this. Second one is orthopnea. That is nothing but breathlessness. I said this is also seen in severe COPD and asthma also, but it is a typical feature of left ventricular failure. Patient, if he goes to lie down, then he will have breathlessness along with pink frothy sputum. So he will prefer to sleep in uh, chair or in a sitting position. Very important feature, orthopnea. Any patient coming like this, suspect cardiac breathlessness. Next is platypnea. This is rare. Breathlessness in upright position and relieved on lying down. Patient stands, there is no breathlessness. When he lies down, there will be breathlessness. Why? Because this is in atrial maxima. So in the heart, there is some myxoma like this. When patient is in upright position, this myxoma will come and this will block this one. So there will be pulmonary congestion backside, and forward there will be decreased cardiac output. That's why he will have breathlessness. And when he lies down, this will go back to its original position. Now, this is very important. Next point. Now we have discussed acute breathlessness, chronic breathlessness. Now we will discuss how to remember these causes of acute breathlessness and how to remember the causes in order to evaluate better of chronic breathlessness. Causes of acute breathlessness in order of evaluation can be remembered after exclusion of airway obstruction, anaphylaxis, and pneumothorax as number one, cardiovascular cause, in that acute left ventricular failure or acute pulmonary edema. Number two is pulmonary thromboembolism. Respiratory cause, most common asthma, COPD, third pneumonia. Number three, metabolic acidosis, diabetic ketoacidosis, renal or poisoning. This is rare, you can remember. Or number four is psychogenic, meaning panic attack. In this manner, you should evaluate a case of acute breathlessness after ruling out these three. Next coming to the causes of chronic breathlessness. How do you evaluate? In case of chronic breathlessness, now you have seen that in case of acute breathlessness, after ruling out those three conditions, first there was cardiac cause. Now you evaluate for respiratory cause first, because chronic breathlessness is mostly seen in respiratory causes. Means first preferred evaluation is cardiac, respiratory. So first to evaluate for respiratory causes. So the common causes are COPD, asthma, interstitial lung disease, and lastly it is lung cancer. COPD, asthma, interstitial lung disease, lung cancer. Remember these two things in the order of evaluation. This is the summary of whole breathlessness causes and clinical features. Then second number is cardiovascular diseases. As learnt, chronic heart failure due to ischemia and cardiomyopathy, constrictive pericarditis or cardiac tamponade, vascular causes, pulmonary hypertension or chronic pulmonary thromboembolism. Metabolic causes, anemia and obesity. Obesity is also a very common cause. Many patients come, I am having breathlessness, obese. You do ECG, X-ray and all, and you will be परेशान हो जाते भाई evaluate करते करते. But obesity itself is a cause of breathlessness. So severe anemia is also a cause of breathlessness. Obesity is also a cause of breathlessness. In severe anemia, patient will have loss of appetite. Sometimes he will have palpitations, okay, generalized weakness, easy fatigability. These are all features of severe anemia. Neuromuscular causes are rare. Psychogenic causes, hyperventilation syndrome, as I explained, perioral and finger tingling sensation. Okay, lastly, if you want to take neuromuscular causes, myopathy means anything. This is the muscle, this is the neuromuscular junction. Here the nerve is going to the spinal cord and to the brain. Okay, this is brain. So anything which affects the muscle, anything which affects the neuromuscular junction or the nerve or spinal cord or from central cause will have breathlessness. So myopathy, myasthenia gravis, this is myopathy, this is myasthenia gravis, this is phrenic nerve palsy, any central tumor cause. Typically, when there is excessive bleed inside the brain, that medulla will come out and it is compressed against the base of the cranium, that will cause respiratory arrest in the patient. So that is a cause of breathlessness. So with this we conclude the definition, mechanism of breathlessness, and clinical causes and clinical features of breathlessness. So these two things these two things these two things are important. How to evaluate for breathlessness? Number one, this one.